My name is Jeremy Ringewald. I'm a pediatric cardiologist specializing in interventional cardiology for both children and adults with congenital heart disease at St. Joseph's Children's Hospital and St. Joseph's Adult Hospital. Well, I think one of the things that's very helpful is this kind of multi-level collaboration. There are also certain procedures that we can do here that can't be done at other hospitals. Okay, one of the the main ones, and probably the biggest thing in the not too distant past that we started doing is the transcatheter valve implantations. The Melody valve became approved by the United States Food and Drug Administration back in the early 2010. We started doing that procedure here in early 2011. Since then, because of the size of our practice and the number of patients we've been caring for so long, we've just found more and more patients that can benefit from this new technology. Again, the Melody valve is actually a cow's neck vein, or what's called a bovine jugular vein valve. Now, those valves had been used for many years prior for cardiac surgeons to use that valve with that vein to actually replace a patient's main lung artery and pulmonary valve. That experience led to the development of the way of sorting out how you can take that valve and that vein, sew it inside of a stent, and then to get that system on a balloon in such a way that you can deliver that into a patient's main pulmonary artery and replace a dysfunctional valve. That technology has really been a game changer for lots of our patients that wind up getting a surgical pulmonary valve replacement. It's changed the way we do surgical pulmonary valve replacements. We try to make sure as best we can that all of our patients who could possibly benefit from that, it's part of their surgical strategy. So we want to set kids up and adults up who get a surgical pulmonary valve replacement for their next valve to be a transcatheter valve, simply because of the overall cumulative stress on their body and their other organ systems, that if we can help avoid extra runs on cardiopulmonary bypass, we should always do that. And so that's been the big game changer of late. With that has really changed the way we look at how we manage dysfunctional valves in general, how we stage their surgery, and how we look at all the details of their anatomy to make sure that this technology now, even if they're not a candidate for it now, if they need surgery now, we'll try to do our best to make sure they're a candidate for that in the future when their surgical valve at this point has dysfunction someday, which is 10, 20 years down the road, but we should plan for that 20 years down the road now, and not 20 years from now when we say, oh, we should have done this instead. And that's really another thing that's very unique. Having that technology here has also kind of changed the way we do both angioplasty and stenting for large diameter vessels, because it kind of exposes you to and has you regularly using a whole new group of wires and balloons and stents and other things that kind of go along with putting in the valve that you otherwise wouldn't have as much exposure to. So you get a lot more comfortable using really large diameter stuff in important places, for instance, in coarctation of the aorta and other diagnoses. So the management of that one problem and the experience with the new equipment for that, dealing with that problem, kind of lends itself then to extrapolate and taking care of other patients. In calendar year 2012, we did as many valves as any program in the United States. And that means, and that other program was Boston Children's Hospital. So we're very proud of that. It's just a way, I think, of showing that we're really expanding the use of this technology to our population group as best we can. And it's kind of a sign, I think, of us really pushing ahead with new technology.